So I did my presentation on how clinicians can measure progress with patients in physical therapy who are there for MS. And what MS is it's a chronic inflammatory disease of the CNS that will demyelinate the sheaths of the central nervous system as well as affect the axons around it. As this disease progresses, it definitely will affect other systems of the CNS and the symptoms will increase, as you can see on the right. That's a percentage out of a study of how many patients will progress with these symptoms, as well as there's no known cure for this pathology, so there's a hard road ahead of these patients who are definitely knowing that it's a long-term thing, and that's where the depression comes in, or the fatigue, or the weakness, where they feel like they don't have anything to give anymore. So in physical therapy, these are the two main measures that they use for multiple sclerosis patients. The image on the right is actually an example of the Modified Fatigue Impact Scale, which is a test that will give you a bunch of questions and a bunch of activities for the patients to do, and they will get a score on that test, and the range is from 0 to 84. And then this will tell you how far onto that scale they are in relation to their fatigue. These different measurements go into physical, cognitive, and psychosocial categories, which will make up that total 84. And the other main test that's used is an ambulatory index, which is similar to a time to walk test with other different measures that are put into place. But the big thing was the time to walk test, which is a 25-foot walk, and then they will rate you with the amount of time it takes you to do this, as well as the assistance that is needed for the patient. So the purpose of the study that I chose was to examine these measures of MS to make sure that they are actually working for patients with MS versus if they are just showing the slight progress, if they're showing any progress at all. For the patients, they wanted to decrease the fatigue and increase their quality of life, knowing that this is a long-term pathology, and they will be dealing with difficulty with some of the ADLs that you see on the right, such as eating, bathing. Transferring is a big thing that they won't be able to do by themselves eventually throughout the pathology. So in this study, there was 209 patients. Out of that, there was 76 male and 133 female. And then their average was about 51 years of age, and most of them had the pathology for at least 13 years. To be a patient in this study, it was out of one single clinic, and this clinic used either the Poser or McDonald scale to rate their MS patients and decide if the patients are actually having MS versus another pathology. Also, the patients were divided into ambulatory versus non-ambulatory. The cutoff for ambulatory versus non-ambulatory was when they did the original modified or the original ambulatory index. The patient had to have a 7 or higher on the ambulatory index scale. So the process to get this study started was that they took 500 files of patients between 2006 and 2008. And out of that 500 patients, they used 295 assessments, which means that out of the 209 patients, there was a group of them that were used more than once. Over the study, all of the patients were 3-month studies, and they were at the clinic on an average of 2 times per week with 1 day of a home exercise program. And then the scales that were being tested, which was the Modified Fatigue Impact Scale and the Ambulatory Index, were tested only at the beginning at the end of treatment. This slide is just an explanation of what each group did. It doesn't have the exact treatment plan in it, but it does have that ambulatory patients did a lot more with the walking, the endurance, the conditioning, a lot of strength training and things like that. Where non-ambulatory patients were limited to passive range of motion, passive stretching, muscle strengthening if possible, active stretching, active range of motion if possible. So there was a very big gap on what each group was doing versus with their ability to move around. So the results for the ambulatory group only, you can see on the right is a chart actually pulled directly out of the text from the study. The top 2 up here are your 2 for your ambulatory index, and these 4 down here are your ones for the Modified Fatigue Impact Scale. So to start with the modified fatigue impact scale, their total score as well, their subscores decrease. So over here is your total score, and then your physical subscore was the top right, cognitive bottom left, and then psychosocial bottom right. Also, when interviewing these patients after the study, a lot of them actually stated that they felt that they improved their quality of life after the physical therapy treatment because they didn't feel as tired. As well for the ambulatory index, which is the top two corners, all the way at the top, the ambulatory index total score did not have much, if any, change in ambulatory patients. However, the time to walk test was decreased, which could relate to the modified fatigue impact scale, how the fatigue increased, the time to walk test increase. But unfortunately, there was no changes in the total score for ambulatory index for these patients. So this slide is the results for the non-ambulatory group for both the modified fatigue impact scale and the ambulatory index. As you could see on the numbers, there was a very small subject size of only 24. So both outcomes were very minimal, if at all. And actually, if you look at the ambulation index in the bottom chart for the top row, the numbers were pretty much exactly the same. And even all the other ones, there was an increase in numbers with the exception of the psychosocial score. So for ambulatory patients, the modified fatigue impact scale was a good tool to use to show the fatigue of patients. But in both the ambulatory and non-ambulatory group, the ambulatory index was not a good scale to show improvement because there was very minimal change in the scores. So a couple things I would like to change with the study would definitely be one assessment for one patient. There would definitely be a little bit of confusion, especially if you're using two assessments for one patient, even if they're at different times in the study, to get different scores. As well as I would definitely prefer that there would be more measurements in the modified fatigue impact scale and the ambulatory index throughout the study, so that way you can see a better progression of how things went throughout the study. And there was no clear treatment plan, so this would definitely be a lot harder to replicate no matter where you go or anything like that. So how does this relate to us as PTAs? It will actually give you a better understanding of how the modified fatigue impact scale and ambulatory index will work with patients, whether it be with MS or not. You could use these scales for other pathologies, such as, different neurological conditions as well. This would also give you a better idea to try to find some scales that would be used for MS patients other than the ambulatory index and modified fatigue impact scale, whether they're ambulatory or non-ambulatory. Another big thing will be patient safety. Knowing what you can do with ambulatory versus non-ambulatory patients will definitely help to make these patients' quality of life improve in their treatment. And this is just the source that I used to get my study from. It's from the Neurorehabilitation Journal.